So I invite Dr. VIKAS MENON, who has extensive work in ocular oncology, and he's currently in Chennai with Arvind Eye Hospitals, and he's going to take us through conjunctival tumors.
Thank you, Fairuz. And a lot of this may sound repetitive for people who have attended our surface IC earlier today. But let it be a revision of sorts. I'll just run through the slides and photos quickly.
Yes, interactive will be really great.
So just a revision basically. So you know, conjunctiva has epithelium, a stroma. So tumors can arise from epithelium, tumors can arise from stroma, and there can be secondary invasion of conjunctiva from the neighboring structures or from distant sites. And broadly, ocular surface malignancies, it's easier to look at them as pigmented or non-pigmented lesions, and that will help you to formulate your diagnosis and localize your differential diagnosis to a fewer possibilities. I'll talk about 5 features that will help you in identifying a surface malignancy. Number 1, a presence of an epibulbar mass, especially if it's a papilliform kind of a large mass. So a papilliform, reddish, large mass, suspect a malignancy. Sometimes you don't see a papilliform mass, but it's still a limbal gelatinous kind of mass which is growing over the limbus. So that again could be a malignancy. So keep that in mind. If you see intralesional vascularization, that's the second point. So if you have a mass which has got lots of vessels growing inside that lesion, so that's like, you know, a sign which can guide you towards a possible malignancy. Third point will be feeder vessels. So the number of points you keep picking up in a lesion that is present on the ocular surface, suppose a lesion has just one of these points, then you know your suspicion is like a little low. But as you keep on adding these various factors, your suspicion should become higher, and more often you will be able to make a diagnosis just clinically. So the third point is feeder vessels. So you see prominent feeder vessels coming from fornices and entering the tumor. So that's like another red flag. Another patient presented with lots of feeder vessels, and you also see a papilliform large epibulbar mass, and the feeder vessels are adding to it. So that's another patient. So another patient, the fourth point will be keratin. So keratin is deposited on the surface of these Ossn lesions because of the high turnover of the cells, and that's keratin is produced, it gets lodged here. So you have a limbal mass, you have feeder vessels, you have some papilliform areas, and you have keratin. So these are 4 points which you are having. So these will help you to kind of, you know, narrow down your differential diagnosis to Ossn rather than maybe a pterygium or a VKC or things like that, or allergic lesion or something like that. Another patient who presented with a nodular lesion at the limbus, you have feeder vessels, it's a mass, you don't really see papilliform vessels there, but you see a lot of keratin on the surface. That again was a patient on biopsy proven to be Ossn. So you will have varied amount of keratin on these lesions depending upon the rapidity with which the cells are multiplying and or they are proliferating. So another patient with keratin, feeder vessels, and the works. Another patient, so exuberant keratinization here. So some of these patients may have very obvious keratinization, some patients may have more subtle keratinization. So you have to keep looking for these signs to be able to make a good clinical diagnosis without the biopsy. But again, you see lots of other signs that we talked about: feeder vessels, mass, area which has got some lesion with an intrinsic vascularity, and keratin. So all these things just add up. And number 5th is the rose Bengal stain. So if you stain these lesions with rose Bengal and see them under the green filter, then more often these lesions will pick up the stain and will also help you to characterize and define the exact extent of the lesions. And this is what you should do pre-operatively in your OPDs on slit lamp, because sometimes you may not see subclinical cells which are still there, but the positivity may sometimes at times extend beyond the lesion itself, and that gives you a clue that when you are planning your surgery, you have to take that area out as well. So Ossn that we just talked about, that's basically ocular surface squamous neoplasia. It's squamous cell carcinoma. or carcinoma in situ or dysplasia. This is just this term that we use. The exact diagnosis can be made histopathologically, whether it's just a dysplasia or you're seeing is a CIN or a carcinoma in situ, or it's a invasive squamous cell carcinoma. So these were some epithelial lesions. Dr. Fairuz just highlighted the need for eversion of the eyelids in these patients. This patient actually presented with nothing but a persistent discharge in one eye for a prolonged period of time, for which she was on a lot of antibiotics, steroids, lubricants, everything tried for a long time. But simple eversion of the eyelid revealed that she had a papilliform lesion on the upper tarsal conjunctiva that was nothing else but squamous cell carcinoma. And again, a patient with unilateral kind of blepharoconjunctivitis, elderly patient, and at extremes of ages you need to be more careful about these lesions. So you have this thickening of the lid margin, and you have this rose bengal staining, and you have a gelatinous kind of mass which is just covering the entire surface. You invert the lid and it's even extending up to the lid margin and involving almost the whole of upper tarsal conjunctiva. So this was again a very diffuse OSSN. You need to differentiate these lesions from pagetoid sebaceous gland carcinoma, as she's mentioned. So just keep an eye open. Sometimes, these patients will undergo a surgery. Somebody will try to operate, and my stress is always that, the first surgery is the best chance that you have to treat these patients. If your first surgery is faulty, then, you're just messing up with the patient actually. And then the subsequent surgeries or whatever treatment we do is likely to be much less effective than the first time if it is primary treatment is good. So patient underwent some surgery. So especially when you have a patient where you have a high suspicion of OSSN and underwent some surgery or something, always do some sort of imaging to see the depth of invasion. And anterior segment OCT is one very good non-invasive modality that we now have, which showed us the depth of invasion into the sclera of this tumor, which is already going into the sclera. So this patient will need management in a different form. So not just excision, but you have to counsel the patient that after excision, you will also have to go for plaque brachytherapy. Another patient who presented with something like a hypopion uveitis, but here you see there is a scar on the conjunctiva. So this patient had actually undergone some sort of surgery. She didn't know what exactly the surgery is, and patient coming from a periphery. But some surgery has been done. You see the scar and you see this kind of presentation, and there are lots of clumps of cells actually in the anterior chamber. So something has gone inside the eye, and you want to know what is happening there. So a UBM is helpful in such cases. You see the ciliary body is thickened. So basically this was a squamous cell carcinoma which had gone inside, invaded the ciliary body, and the cells were seen in the anterior chamber. Now such patients would require a more radical treatment. The eye had to be removed, of course. In most other cases where the tumor is nice, superficial kind of a thing, then topical therapy helps. We've spoken about this in detail in the earlier IC. So the most preferred treatment, topical therapy that we use is interferon, topical interferon. This was a patient, gelatinous mass, disappeared after 2 months of interferon. Another patient with a slightly larger lesion, which completely regressed in 3 months after topical interferon. So there are specific indications for topical chemotherapy, not that every patient you give that interferon or mitomycin blindly. So basically, one is that if you are planning an excision but the lesion is too big, so you want to reduce the size of the tumor, then you give topical chemotherapy and then take up the patient for surgery later. If it's a very diffuse lesion where you think surgical excision will not be possible, that's one indication. If you've done a surgery and the excision edge reveals a CIN type of lesion positive in the edge, not invasive carcinoma in the edge. If it's an invasive carcinoma on the edges, then you have to go back and do surgery. But if it's like a intraepithelial neoplasia in a positive edge, you can start a topical chemotherapy. If there are multiple recurrences with treatment failures, pure corneal lesions or elderly or debilitated patients not fit for surgery, there you can try topical therapy. Surgery is the gold standard for most invasive tumors, and we do get good results with the standard technique of a no-touch technique, taking a wide margin around the lesion, clearing up the entire thing, and then adding adjuvant cryotherapy at the time of surgery. That's the best time you want to add adjuvant therapy. So cryotherapy to the remaining edges of the lesion, of whatever conjunctiva is there left behind. So you add cryotherapy, double freeze-thaw cycles. We saw a video earlier in the day, and then covering the defect with the AMG. The results are usually very good. Moving on to some of the stromal tumors, Stromal tumors basically it can vary a spectrum. It's a spectrum from benign to malignant tumors. So this child presented with a pinkish mass with some intrinsic vessels. So when an abnormal vascularization is seen, so even if it's a younger patient, then we have to see what is it. And this patient was taken up for biopsy. It turned out to be a benign reactive lymphoid hyperplasia. Whereas this elderly patient came with a similar looking mass with a lot of vessels in the lesion, a large pinkish mass. You couldn't see the posterior extent, so in such cases imaging is required, biopsy is required. This is a classical case of a lymphoma, malt lymphoma, and depending upon whether there is systemic involvement or not, you plan chemo or radio. Pigmented lesions we just discussed short while back. I'll just run through. Basically, there are a few types of pigmented lesions that we see in EY, where you need to look at these cysts, which tell you that it's a nevus and not really a malignancy. And this is something which you need to be more careful about. This is primarily acquired melanosis, which is like a irregular diffuse pigmentation of the conjunctiva, and it can be with or without atypia. If it's with atypia, there are high chances of having a melanoma like this. So this is basically a melanoma which developed from a pre-existing PAM. Most of the melanomas develop from pre-existing PAMs with atypia. So these are just the cases which we saw earlier in the day also, and some of them are fresh. So thank you very much. Thank you, Fairuz.
Thank you very much, Dr. Vikas, for an excellent overview. Do we have any questions for Dr. Vikas? I'm sure conjunctival lesions is something that even a general ophthalmologist would be managing in their practice. Sir, do you have any questions? All right. So we go on.